Hi, everybody. It's Dr. Tiffany Lamberton of TMD Collective, and this is another episode of Jaw Talk Podcast. Today, I get real with my friend and colleague, Dr. Lynne Thomas. She is a dentist from San Diego. She's also part of my Chicago study club. She's a graduate from the University of Michigan School of Dentistry in 1995. Her practice is dedicated to families who value the complete health model. She specializes in the use of digital dental technology to enhance smiles, optimize function, and improve the harmony of the stomatognathic system. Dr. Thomas's passion for dentistry motivates her to train future generations of dentists to help them by expanding their knowledge and application of skills in restorative dentistry. Let's dive right into this great episode with Dr. Lynne Thomas. Quick legal disclaimer: all information in this podcast is the opinion of the speakers and not meant to be a substitute for a diagnosis and consultation of a qualified healthcare provider. Hey everybody, this is Dr. Tiffany Lamberton of TMD Collective, and this is another fabulous episode of Jaw Talk. I am so excited for my guest today, Dr. Lynne Thomas. Welcome to the show.
Thank you, Tiffany. Thank you for having me. I'm totally honored.
Well, I want to tell people just a little bit, our audience, we met through a Chicago Study Club, which is an amazing group of elite dentists that meet twice a year in Chicago. And this past May, I came to you and said, I want you to come be a speaker for my Women in Dentistry event. And you were so gracious. And then you came back to me and you're like, okay, let's do it. So thank you so much. And we'll talk a little bit about our event and the fact that you're going to be one of our amazing speakers. But I'd love to give our audience just a little bit of background about you. So they heard your bio, they know how accomplished you are, but tell us a little bit about how did you get where you're at today?
So I kind of have maybe a little bit different background. There's so many women involved in dentistry today that it's quite possible that we have more assistants going into dentistry, but that's kind of where I started. I actually started in dentistry at the age of 16. I've only done dentistry. It's the only job that I've ever had in my life. So I really got lucky in the fact that I got led into this direction because I love what I do and I love taking care of people. It's phenomenal. And I love my colleagues and educating. And so it's really the right fit for me. I was blessed in that I was able to work in a perio office, work in an endo office. And then when I was in dental school, I actually worked in very varying general dental offices that ranged with all different kinds of philosophies. And it was very insightful and gave me a lot of direction. So I went into the Air Force so that I could work on perfecting my skills a little more and I could travel and see the world, which was wonderful. I loved being in the Air Force and serving my country. And I got to do great continuing education programs, very similar to like a advanced education general dentistry program where I would go 8 weeks and do pros. I would do 8 weeks of perio. I got sent on for those continuing education programs and it was amazing. I loved it. And I learned so much clinically and talking to my colleagues who had so much experience. It was a great opportunity. Plus, I got to travel. I lived in Germany for 4 years. And that is actually where I met my husband, who is a German trained dentist. And that also has really been very insightful, living and practicing together. We've learned so much from each other. I think one of the funniest things is that, we have a lot of things that get lost in translation.
So I love your story of how you met.
Yeah. So once we got out of the military, we both exited the military in 2001, right after 9/11. And we decided to come to California and join forces together here. Part of the reason for that was because my family was here. I had my brother here and my mom, and they were, my brother and his wife were having kids. And we just kind of felt like San Diego was the right fit for us. So we came here in 2003 and we opened a practice. We actually opened 2 practices, which we later consolidated, which actually ended up being the best thing that we ever did because we were kind of spread too thin, having 2 practices and young kids and trying to maintain your team in both practices. And if we wanted to go for continuing education together, well, both practices would have to be closed. So it just got to be too hectic. And when we consolidated, it was the best thing that we ever did. So before I go into that, though, I want to talk a little bit about how I got to be more of a digital dentist versus an analog. So I came out of the military in 2002. And then when we became civilian dentists, right, that's what we called them, we were trying to set up our practices where we would just have predictable results. And we consistently, well, we were just having issues. We didn't want to have our new patients, right? Because when you buy two practices, everybody is a new patient. And when you're doing routine procedures like crowns, we want it to go smoothly. We don't want to have remakes. We don't want to have the color off and all of those kind of things. And we were kind of running into that. We were kind of like, I think we can do this better. And that's where we invested in CEREC technology and decided to make that part of our everyday practice. So people would come in, they really liked the idea of only having to get numb once. And we did have limited materials, but now we have a plethora of materials that are phenomenal and has really raised my IQ on materials and where they're applicable and where you want to use them. So that's just been something indirectly that's happened to me that you don't even realize what you know because you do it on a daily basis. So we decided to go with that technology, and it's been great because in our daily practice philosophy, we have always been very bite driven. So we came upon Jimmy Eubank. He was one of our mentors. And Jimmy had like a whole system for evaluating people who consistently had problems with their bites. So, what would that mean? That would mean like people who come in and they're breaking things all the time. They've had a lot of root canals, or maybe they've had a lot of implants. They have a limited opening, all of those kind of things, just issues. We thought we need to employ some kind of system, some kind of checks and balances that allows us to properly diagnose these people and make sure we're not overlooking anything. So we implemented photos, and when indicated, we would tell patients we need additional diagnostics. Those would be in the shape and form of, centric related models so that we could evaluate their bite, and then really just taking our time and determining what options does a patient have. Yeah. So that was like 2007. So what's really great in our practice is we started off with the AACD photo series, which is a series of 12 photos. And we have had photos on our patients now since 2007. That's almost 20 years. And it's great when we're looking at people who are suddenly not stable anymore and what's going on. And we can track
Like
with our photo
changes over
history,
time.
what has changed? Have we changes in the bone architecture? Do we see a wear pattern that's suddenly been introduced? Of course, these things are usually gradual, but it's so great when you're taking photographs.
Same position or
Right. So that was one of the things that was really great about the AACD is that they want your photos to be shot exactly the same so that they can have your before and your after, and they're really able to compare apples to apples. When you have something that has a different size, that doesn't work. And we all see stuff on the internet where the before and then the after totally looks different, probably because it's been photoshopped a little bit. But when you use raw images, it really is very telling and makes you very honest.
yeah.
And so I like those kind of challenges, which is why the ACD has always been a really great organization for me to belong to, because it makes me do my best dentistry, which, yeah, that's what I want, and to be able to assess what you're doing is great. Anyway, going back, sorry, I went off a little bit on a tangent, but I have a little bit of a bite issue myself. I'm class 2 and I have a significant pop in my jaw. And, I've had some issues with function and discomfort, and then I had patients who were coming in. And as we introduced the additional diagnostics in our practice, we became even more aware of, okay, here are these patients. We know what we can do for these patients. But there's these patients, like, what is going on with these patients? It doesn't really fall into anything.
Coupling.
So uncoupling, but like, yeah, there's just been some variables, which I'm actually super excited to share with you at your symposium, some of those cases, because we all have those things, right? There used to be kind of a joke in our practice, like, how do you know? Do you ever have those models that you've mounted and they've collected dust? Because what are you going to do with them? You don't know. You've looked at, you pick them up every once in a while, kind of move around their function a little bit, look at their wear patterns, and then you're just not exactly sure what to do, you know? And so this is where today, and being introduced to Jim McKee and understanding everything that he's experienced and sharing with all of us clinicians, that it was such an amazing aha moment that I actually got emotional. I was ready, teary eyed in his course because I just thought, oh my gosh, this is so the missing link. This is exactly where a lot, because when you're going through conferences, and you're hearing, clinicians like Pete Dawson and John Coyce and Frank Spear, or who's the other guy, the implant guy, Carl Misch. You hear those guys speak and you're just like, oh, that's my patient. That's just like this person. That's just like that person. And then you get that information. Then you come home and you take out those models that you're like, okay, let's look at this again. So all of that information helps you become a better clinician and provide better options and answers for patients, having them understand their risk factors more. And that's where Jim has been really instrumental for Jurgen and I, because, we have those patients and now, yes, we're introducing more and more diagnostics, so let's look at an MRI. Let's see what that jaw joint looks like. And while we're still employing the same thought process for what avenues or what potential options are going to be available to this patient, at least the patient has accountability for their problem. They know what the status is of their jaw joint and they know what their risk factors are. So now you can talk about non surgical options, surgical options, and then they can choose which
What's
way
right
is going to
for
be
them.
the best for their lifestyle, really,
Yeah.
because that's what you're talking about, is what is going to work into that patient's lifestyle. So one of the things that we always talked about quite a bit, or who straightened this out for us, was Pete Dawson, who always had the four options for what do you do with people with bite problems. It's on a gross level, not on a tooth level, right? And that would be, you can reshape or equilibrate, or you can restore, or you can reposition, do orthodontics, or you do a combination of these three things, or you can move bones around, with orthodontic surgery. That was really helpful because it really helped me determine what were going to be the best options for people with bite issues. And now bringing in that piece that Jim McKee has been so amazing to share with all of us and mentor us, because he's a phenomenal mentor. I don't know how he's always available, but he is. And
And so generous with his knowledge.
he's so generous, really. And well, not to mention, the rest of them, Kurt, Drew, Seth. I don't want to leave those guys
Yes.
out either, but, they're also amazing and always available. But now, I feel very complete. And that is such a great feeling for a clinician, because when I have people who are coming to me who need help, I feel like I know how I can help them, what I need to help them. And it's just been really rewarding. So I'm in a good place now.
I love it.
Yeah. I love my digital dentistry because, Well, there's a number of different reasons. I'm going to turn it over to you now.
Well, I think what's really important and what I want to showcase, when you come out in September and speak is just how do you start to put all of those pieces together with your workflow? Because you mentioned you've got the clinical photographs. Now, instead of taking GUI impressions, we're doing digital scans. Now we have the advantage of cone beam CT, and now we have the advantage of MRI to be able to look at, not just the teeth and the bite, like you mentioned, but also overall, what
Yeah.
else is happening with the skeleton? What else is happening with the TM joints? What's happening with the airway space? What's happening with the cervical spine? So I think that as dentists, we tend to get like really focused in so much about, occlusion and that. But like you said, when you start to see those failures of, people breaking teeth or, kind of progressing with a progressive bite shift, or maybe starting to develop jaw joint symptoms, like you mentioned, limited range of motion, clicking and popping. What do we do and what's predictable? And so I love that you said you have to own your anatomy. And when you can show that to a patient and explain to them, this is what we're working with, this is the skeleton, this is the soft tissue. And then it's not us that is making the decision about the treatment, it's the patient. So I love that you mentioned that.
In so many ways, I kind of just feel like I'm just the messenger. you know, I know what I know, and I'm going to share with you what I found, and then we're going to have a conversation about what you think is going to be the best fit. So now I've been a dentist for almost 30 years. And I think about certain landmarks, like what were things that really changed what I did? Loops, of course. Everybody's getting trained on loops today, but they weren't always. So loops were huge. I had an impression material that I don't use anymore. I haven't used impression material in 15 years, but Improgum was my go to impression material. When I found that, everything became so much easier. My digital scanner now is amazing because in 2 minutes, I can actually share things with the patient about their function that you can't really get from photographs. We have patients even today that come into our practice who are like, I've never had anyone do this many photos. And yes, most people uncomfortable with having photos done, like, I didn't know you're going to do this. And then they think we're going to put them on Facebook or something. But when we explain to them the metrics that we're looking at, then it's a whole different ball game for them, and they totally get it. And yeah, so those things have been, really big, what do you call it, landmarks, like introduction of the scanner and being able to fabricate our own crowns, and then having our diagnostics under wrap. Having a
Right.
CBCT, I fought Jurgen tooth and nail about that. We don't need a CBCT. We don't need that. But no, when we did, I was like, oh yeah, we need to get that volume bigger so we can do jaw
Yes.
joints now. Yeah, it is essential. And it's just incredibly useful in my daily practice for almost everything. I tell you, the CBCT is phenomenal.
Yes. Well, and talk a little bit about how you use 3D printing too, because I feel like that is also just really revolutionizing, where we can do provisionals and you can give patients an idea of what their smile is going to look like.
Yeah. So for printing, we're printing models. We print all of our models. We still do articulation for our models. We don't rely on virtual articulation. We're not quite there yet for us. So we go ahead and we print our models, and we have all of the bite registration records that we mount on our articulators. So printing has become huge from that aspect. So we use it for models, we use it for night guards or orthotics, depending on what the patient needs. And we do a whole lot of that. I love that. I'd like to see a little more advancement with the material options for our night guards or orthotic materials. We're still not quite where we need to be. In other words, if I compare it to an acrylic made analog splint or night guard, it's not quite as good as it is with the acrylic. So I like to know both of those techniques. How can I make it myself with just good old acrylic and monomer? Yeah, you remember? Like, did you make temporaries with that ever?
Yes.
And it got all hot and would burn in your hands. Yeah. So that stuff. But also, the for most individuals, we can get night guards and orthotics done without any problem. And what's great about that is then we scan the orthotic once we have somebody really comfortable, scan the orthotic, and we have now an STL that we can reproduce should the patient's dog get to it or left it in the Kleenex at the hotel and then the staff took it and threw it away. We've had incidences where, for instance, Dr. McKee has had patients that have moved to California and they lost their orthotic that he made them, and he would send me the STL. I'd print it and deliver it to the patient, and it works seamlessly. Other aspects, doing like diagnostic wax ups, I can just send out the STLs to my lab technician, and then my lab technician goes ahead and does his diagnostic wax up and sends me back the STL, and then I print it. And then, like you would with any wax up, you would then do your putty stint or your copyplast, whatever you like, and then you would transfer that into the patient's mouth so that they can actually get a little preview of what that diagnostic wax up would look like. As far as temporaries go or prototypes and fabricating them, I will print them off, but I'm still milling a lot of my prototypes because it's faster for me to do that. And yeah, I print some things and then I mill other things. So I kind of like to be able to have that option. And I'm going to actually discuss a case at our meeting, at our symposium, where I've actually used a whole combination of, I had somebody actually make the lab PMME, and then he sent me the STLs in case they broke while I was working. But I milled out the anterior segment, and the patient actually had fat replacement, disc replacement with fat pad, fat
Autologous
transfer.
Mm-hmm.
Yeah, Dr. Shaw.
Dr. Shaw,
And
yeah.
so while her opening improved, we were still very cautious in the fact that we didn't want to leave her open for extended periods of time. We wanted to make our work very efficient so that we didn't, again, overexhaust her or put too much tension or stress in those areas. So I'm going to discuss that case in quite a bit of detail so that everyone could kind of see how Dr. Shaw and I collaborated. And it's really turned out great. She
I
is
love that.
now 2 years post-operative, and she is so stable and she looks great. She really looks great.
And that's like such an amazing example of interdisciplinary care where
Yeah,
digital dentistry workflow allows you to work with our oral surgeons with and
it does.
communicate easily back and forth.
Yeah, it
So
is great. I have several incidences. So like CBCT, for instance, and I've been doing a lot more endo. Actually, I feel like an endodontist, to be honest with you. But your CBCT is so helpful because you can identify all of the anatomy that you're going to be attempting to do. So, number one, I can make a decision about whether I feel that that is going to be something that I can complete for my patient and in the manner that I want to complete it in. Or I can just say, no, I'm going to send this to the specialist. This anatomy is too complicated. Let's go ahead and send that out. However, I have had anatomy that was within my scope of care, I felt, and I've had an instrument break, right? So that was like, oh my gosh, I can't believe I just broke an instrument. Had my first one break like 2 months ago. So what I did is we did the CBCT, and then I uploaded that through a communication software through Dentsply Sirona that to another endodontist who could open my whole CBCT and to see exactly my situation. And then he walked me through on the phone how I could handle that situation for the patient. It
that's
was
amazing.
so cool.
A bad day and completely turned it around.
Yes.
You had that
Yes, it did.
mentoring.
Oh my gosh, that really can ruin your day when you break an instrument in the patient's
Yes.
mouth. That's for sure.
That's why I don't even do endo anymore. I'm like, I can't perform at the same level that they can with their all of their technology and their gentle wave and all of that. So I'm
Yeah.
just like referred.
And I avoided endo for a good portion of my career, partially because my dental school ruined my experience, but I wanted to be an endodontist.
Oh, you did.
I was on the track to become an endodontist. And I had not the greatest experience at my dental school. And then I was like, forget that. I'm not doing that. These guys are jokers. And so I came out, and then I just never felt proficient enough But today's systems, if you have all of the equipment that you need, it makes it so much easier. I mean, they're really good now, and then, like I said, I have my CBCT. So if I don't feel like it's something that I want to tackle, I know that that I'm going to go ahead and send it out to a specialist.
Could you ever imagine practicing back in the 2D world, or where you like dipped your little films and they're like, no?
Yeah, yeah, I know.
Oh, I love applying that same principle to the macro of, as we're now able to see the skeleton, we can see the TM joints, we can see the cervical spine. Why would we go back to two-dimensional imaging now that we've progressed?
That's a great point. I actually tell my hygienist, when they have a patient that comes in and they're like, oh, this tooth has been bothering me, if they're having biting pressure and it's not a recent restoration, I don't even want a PA. I want to see a CBCT. So you can take a limited view on your CBCT. And yes, it does cost a little bit more, but it's under $100 that we charge for that. Patients are always willing to do that because they know how comprehensive it will be. And nobody wants to have a root canal if they don't need a root canal, right? So it's a tool that just allows you to be really confident and accurate, and you can be sure that you're on the right track of providing the best care you can provide for your patient.
How digital dentistry and digital workflow is just, it's speeding up faster and faster. But, part of the meeting that we're going to be having in September is just really showcasing, it doesn't matter if you're, a newer dentist or a more seasoned dentist, maybe you're starting to bring this into your practice, starting to be able to like utilize those systems, I think are going to really like level up your practice and allow us to provide better care for our patients, because now we can see exactly what's happening.
Yes. Yes, you are 100% right. We're not a high volume practice. I know that there are CEREC doctors out there who can do the 90-minute crown, but Jurgen and I have never been able to get that done. It's usually about 2 hours that patients will spend in our practice when we do crowns in a single visit. One of the things that I really love about CEREC is that it does give me the ability to treat people who may be compromised medically. For instance, I recently had a patient who does have a modified jaw joint. And she also, about 15 years ago, she fell out of bed and suffered a concussion. And she has had the severest form of vertigo ever since. She has seen so many clinicians, but you know how you sit upright in your plane, right? And then you maybe go back like, okay, that's great. Nope, now I'm totally comfortable. Well, that's how she's lived the last 15 years of her life. She cannot lay down, so she needed to have some restorations done on her second molars. And I'm like, there is no way that I will ever be able to get in there and do this for you. So we had our anesthesiologist travel to our office, and we were real careful about the angle. We got her not, completely flat, but probably around this angle, which was great for me. I put my isolite in, got to work with the preps, took it out, fabricated the crowns, let her jaw relax while I was doing that. This fabrication of 3 crowns takes, probably a good hour and a half. And then I delivered all of that for her while she was completely sedated. She suffered absolutely no repercussions. Her vertigo wasn't triggered for days. She was totally fine, which I thought was a huge success. And then we got great restorations completed for her. And it was, probably a 5-hour appointment. So yes, it was long, but it was worthwhile. Another thing about doing CEREC dentistry for TMJ patients is, we all know they have those very unique formations or carvings, right, on their teeth in the back, specifically the second molars. When you see something like that, you know that you can copy that exactly with the CEREC, copy that morphology, because we have that capability. So I don't have to compromise the patient's ability to function or potentially have other issues with the morphology. So that too has been a huge asset, having CEREC in your practice.
I
So
love
it's been
that.
fun.
Here's a little bit and talk a little bit about mentorship, because one of the things that I've heard is just, when you get done with dental school, there's just so many different directions that you can go with, How do you go about your practice? What kind of practice do you want to work in? And I think, especially as being women in dentistry, we have unique challenges. We know now that in 2021, 2022, over 55% of each graduating dental school class is now female.
Yeah.
And so, what I want to bring to the table is this idea that we can build each other up and help each other with these different seasons of life and the seasons of our practice, and learning to recognize each other's strengths and weaknesses, and also elevate everyone around us. So I know that I'm not an expert in some of the things that you are. And so I can be like, Dr. Thomas, what should I do in this situation? And so I do want to create that culture and create that environment with our symposium, and bringing in different speakers, bringing in female-led speakers. What would you say, as a woman in dentistry, what has been some of the unique experiences that you've had with mentorship?
So I've always belonged to some kind of study club. I first started off when I got to San Diego, because in the military it was totally different. In the military, I had several colleagues always around me of different disciplines, different education, and all American education mostly, but it was different, but I did get a lot of mentorship in the military. However, once we got into our civilian sector, we were kind of like, okay, well, what do we do now? And so we joined the RV Tucker Club. That's a gold cast study club. So we did that, and we flew our mentor down from Seattle. Dr. Warren Johnson was our mentor. Every Saturday, we would meet up, bring a patient, prep our patients, and he would give us advice about our preparations and our final product. We had 2 sessions, prepping and delivering the gold and finishing the gold. So that was always a great opportunity for mentorship. And then, Spear kind of came along and they had their study clubs. And a lot of my really wonderful colleagues in this area, and meeting them and just sharing information in a safe and secure environment has also been really great. And I really love that, but you have to be willing and you have to be committed. I don't know what it is about dentists, but male or female, I feel like there are times when people don't always want to be completely out, really open themselves up. I don't know if I'm making sense there, but they have to be
The
open.
vulnerability, maybe?
Yeah, I think that vulnerability is really probably the proper way to say it. I love to educate, and I feel that sometimes, and I'm going to share a case where I didn't know what to do, and it's always great to get suggestions, and hear about what we could have done. What could we do for that guy?
Mhm.
But people need to understand that we all come from different walks and we all have different perspectives. And so my husband and I work very differently. The way he gets from point A to point B is like totally different, but that's what works for him. And he has great success with that. And for us, our point B is the same. How we get there is totally different avenues. And I'm very much a checkbox kind of person. I need to make sure I have this and that, and that's what works for me. So my point in sharing that is that there's so many different experiences and routes and ways that people learn, that you just have to be very vulnerable and put it out there. And I think that you will learn so much. And that was something that was really very educational for me when I was in RV's Tucker Club, because, there I was like the youngest and I was the only female, of course. And all the guys were like 75 and they're casting and waxing their own stuff. And I'm like, holy cow, I'm like 35 at the time. And, it was really intimidating to show them what I was doing. And, I almost had weekends where I dreaded it because I thought, man, if this doesn't show up, like I'm going to look like such a fool. But that wasn't the case. But I felt that way. And then I got over it. The more I showed my stuff, the more I shared. And yeah, you get over it.
I
And
love
we're all
that.
human. And I think,
Yes, we are.
yeah, nobody is perfect.
Yeah,
So I think
yeah.
it's really about that. Now, what I think is really great, Tiffany, nowadays that really helps women so much is that we have online learning. And online learning has really opened the avenues for so many women who got to come home, take care of the kids, cook dinner, and then the kids go to bed. And then you can come online and you can learn things that, hey, if you had to be gone, I mean, just the logistics of trying to make it to your study club and having your husband or whoever it is, take care of the kids while you're gone,
Mhm.
it can be
Yeah.
really tricky. And this makes it so much easier for people.
Yeah. Well, I think I also celebrating just the fact that there's going to be wins and then there's going to be struggles, and if you have a community that you can lean on and kind of a collective of a shared experiences, shared space, whether you're a specialist or a general dentist, I'm all about working together as interdisciplinary, learning from each other. In my case, I did physical therapy before dentistry. I always felt like it was so fun in school, because you could just walk across the clinic floor and you have a specialist there. I think sometimes when you're out in private practice by yourself, you lose a little bit of that experience, but
Mhm.
hoping to kind of
You're right.
recreate that.
Yeah, I think for Jurgen and I at this point in our lives, we would just love to have a study club. We'd love to have like a lot of study clubs. We'd like to have a CEREC study club or a digital study club. We'd love to have a study club that's more about comprehensive care,
Mhm.
and complete, doing talking about the complete dental model, and that would be great. It just takes time and you have to get commitment. And other than that, what I do currently is I'm always inviting people, hey, if you have any questions about cases, let's put together photographs. Let's go ahead and have a discussion about what options you have. That is completely
I
not
love
an issue.
that. I love that. I know you're very generous with your expertise, and I'm so excited. I want to talk a little bit here at the end just about, kind of looking forward. Obviously, if you've been listening to the podcast, you know that we're having an interdisciplinary perspectives uniting women in dentistry. It's the first of its kind. I hope it becomes a yearly thing where we have this dedicated group of women that can come together and share all kinds of things, not just about dentistry, but also about life and, how do you share your kids on social media and protect them and, all those
Yeah.
different kinds of questions, but also builds a safe community where we can ask questions and elevate each other. So I'm so excited that you're going to be coming. Tell us a little bit about what you're looking forward to.
Well, I'm looking forward to first and foremost collaboration. I'm going to be presenting, but not lecturing, because I really, whenever I present, I like to collaborate. It's really important and essential for us as clinicians, if we want to learn, to think of, we're in this together, one big happy family. But who has ideas? How did they approach this? Did they have a situation similar to mine? And what are some alternatives? Because there are lots of different ways to get from point A to point B. So I'm super excited to share the things that I have lined up for everybody, and to hear different voices, different ideas of how we can, as a collective, make our patients healthier, because everything we do is to bring patients on a higher level of health. And we have so many great speakers who are going to really go in to talk about things that I've not even heard yet, about growth and those things that are going to help us take care of our kids. And that is really the most important part, I think. I'm super excited to hear that, because we're always thinking taking care of adults. But if we can get to these things before, there are adults, then we're going to make sure that these kids in our world today are going to have a much better life and not
Yes.
have to have these problems with airway or attention issues or
Mhm.
all of that stuff. We're going to elevate their health.
I always say that like modern imaging is almost like a crystal ball for these patients because you can start to predict better when they're 6, 7, 8, 9, 10 versus like the 35-year-old who's sitting in your chair with her jaw locked closed.
Yeah. Yeah. It's really super challenging, isn't it?
Yeah. Yeah.
So we've got a wealth of information to
Yes.
share with everyone, and I'm super excited to be part of that. Thank you very much for the invitation and allowing me to share my passion. I think is probably the best way to say it.
Well, I'm so honored that you agreed to come. And Dr. Lynne Thomas, come out to Tacoma. I'm just so excited to show you my city and do Pilates with you. We'll do some shopping, some wine tasting, and really just learn and grow together.
Fabulous, Tiffany.
Thank you
Thank you so
so
much.
much. Well, where can people find you? We'll link everything in the show notes, but if you have a preferred method, do you like to be on Instagram, LinkedIn, email?
So the best way to reach me is probably through Instagram or email or my website. You can
Okay.
find a lot of information on our website. We are kind of constructing things a little bit different on our website,
Yeah.
but at this time, I think it's still got some good resources there. Other than that, I always share my email because I'm not really that great with social media. If you really want to get a hold of me, the best way to get a hold of me is through my email.
Okay. All right. Well, we'll make sure that we have all of that linked in our show notes so our audience and our listeners can find you, and include the link for our symposium, our Women in Dentistry event that's going to be happening September 6th and 7th in Tacoma, Washington. So all of you general dentists, dental specialists, female orthodontists, perio, pediatric, we want all of you to come in. Let's share together and really build a collective for comprehensive care. So thank you again, Dr. Lynne Thomas. I so appreciate your time and for coming on Jaw Talk with me. And
You're welcome.
what I always say at the end is stay humble, stay curious.
Yeah, 100% agree with that. Thank you,
So,
Tiffany.